Welcome everyone to our August board meeting. And I am sitting here as we all are on the ceded grounds of the Colville Confederated Tribes. And everywhere we walk, every place we go has once been walked on by our ancestors of the Colville tribe. Super proud of the tribal nations this last week when we had the canoe journey that took place on the coast at Muckleshoot. It was a tremendous output of culture and excitement and a little bit of danger, I guess, and going across the ocean fields or on a canoe. But this weekend is the Colville Confederated Tribes Stampede, OMAC Stampede. So we will be celebrating their nice, wonderful powwow if any of you get a chance to go. And then, of course, the suicide race. So that'll be my welcoming of everyone to our lands. I'll go ahead and also talk about the Zoom. We had a little discussion on who was the CS on the call. We got that all figured out. So if you get a chance, if you have the bandwidth, if you could turn on your cameras so that we can see your faces. If not, we understand. Especially right now we have a little bit of stormy weather going on and some of us may have some issues, but wanted to offer everyone the Zoom etiquette and using the chat box, please, or raising hands. I'll do the roll call now. Carlene Anders.
Yes, I'm here.
Okay, Dell Anderson. I'll come back for that. Manuel.
Present.
Yay, thank you. Ray Eichmeyer.
Here.
Maybe. We'll check back again. Senator Warnick. I see your face.
I'm here.
Yeah,
Sorry, didn't get it up.
Molly,
Okay.
Molly, I said I was here too.
Oh, good. Thank you. Hi. Linda McKay. Back. Rosalinda Kibbe.
I'm here.
Thank you. Dr. Tuggy.
Yes, I'm here.
Thank you. Maddie Osborne.
Good afternoon, I'm here.
Thank you. Hello. Teresa Atkinson.
He's there.
Yeah, I see her face. Nancy Spurgeon.
I'm here.
There you are. Peter Morgan.
I'm here.
There you are. Okay. Linda McKay. Did she come on yet? And Dell Anderson. We'll just watch for them and have them chat in when they are present. If there are any declaration of conflicts after reviewing the agenda, if you could just let us know. And if not, as the meeting goes along, you can always chat that in if you do have a conflict of interest. We all work so closely in all of these items that sometimes that does occur. Any public comments at this time? I also ask that our guests chat in their name and their organization. Open for public comments. And hearing none, I'll go ahead and open up to the board to approve the consent agenda, which are pages 1 through 9 of your board packet.
This is Carlene. I'll move to approve the consent agenda.
Thank you.
I'll
Do I have a
second that.
Okay. Any questions at this time on the agenda? Hopefully you've all had a chance to look it over. It also includes the minutes from last board meeting and the financial report. Hearing no comments, I'll go ahead and put it out for a vote. All those in favor say aye.
Aye.
Opposed would be nay or abstain. Motion carried. Thank you. Consent agenda is approved. That brings up John with the executive director update.
Thank you, Molly. And again, thank you to all the board members for joining us today. I'm going to try to be a little quick on my executive director update because we have some pretty great things going on. Really, a few things I just want to call out is you'll see at the start of the agenda some of the work that's been going on with the finance committee. Go one back so far, Mariah. Around some of the resolutions update, and I just want to give a props. I know that committee has been active as we've looked at different processes. We're also going through our first ever audit, and Sarah can give an update on that. But Sarah, Kristen, and the finance team has been doing an amazing job with that, as well as the work that's been going on with our governance committee. And I know that Sarah Bates will be giving an update on the governance committee as well. And just it's great to see this work progressing and moving along as we look at evolving what our organization looks like. We're also going to hear a good report on our telehealth work later on by Ingenium, and Wendy will be leading us through that. And that's been a big initiative push we've been doing for a few years. We're going to see some of the current standing in that work, as well as hearing from our Hope Squad partners with Alyssa Polson and Dr. Rickard on the work that has been going on with that grant we've been funding for the last couple of years. So it's just exciting to see and hear from the work that's going on. It's exciting to see the progression our organization is making. And I'm looking forward to it as we move into this next year, of course. Next slide. One of the things I want to call out is, a great progression in our organization is I want to welcome Veronica Ferreras, our new Director of Network Development. She joined our team July 1st, so she is basically 1 month into this organization and has been just hitting the ground running. And I also asked her to take a little bit of time to share a little bit about herself. So I'm going to turn this over to Veronica.
Thank you, John. I just want to make sure everybody can hear me okay. All right, so
Yep.
I'll just get started. Good afternoon, everyone. Thank you for your time today. I'm Veronica Farias. I am a Mexican-American and proud daughter of immigrants. I now live in Wenatchee, but I'm originally from the Manson-Chelan area. I'm blessed that I still have my family up north whom I visit regularly. I grew up in farm worker housing and, witnessed my parents just hard work day in and day out. I too thinned apples and picked cherries throughout the summers and will bow down to anyone who continues to work in the ag industry today, including my parents. After I graduated Manson High School, I attended Wenatchee Valley College and eventually transferred to a prestigious school I knew nothing about. I was a first-generation college student attending Gonzaga University. It wasn't until I found myself alone at orientation that I realized I got accepted to a private, Catholic, and very expensive school. If you've ever worked a long hot summer day in an orchard, you learn to appreciate the value of a dollar, and I just could not place such financial burden on my parents. So I worked hard and paid for my own education. I worked part-time all through college, and thankfully I was offered a full-ride scholarship to study abroad in Florence, Italy. And this is something that I am just extremely proud of, given my upbringing and my family's circumstances. That experience alone was worth the full cost of my bachelor's degree. I eventually moved back to the Valley. I met my now husband, Martin, and for the past 7 years, I had been working at Chelan Douglas Health District, which is where I've had the honor to meet some of you, some of the board members on the board. Towards the end of the pandemic, I found myself searching for what I now know as meaningful work and wealth. And this isn't to say that my work at Chelan Douglas Health District was not meaningful. It certainly was. But once I came across the Thriving Together North Central Washington rebrand, I instantly connected and was intrigued by the vital conditions framework. This idea of all people and places thriving together, no exceptions, made me think of my own family and friends who have previously been that exception. I was ready to not only challenge this statement, but become a part of this new vision. As the new Director of Network Development, I look forward to spearheading our network efforts together with the Stewardship Council members. I've had the honor and pleasure to meet some of you already, and am just amazed about your own stories and your vision behind this work. So appreciative of the opportunity to be a part of Thriving Together North Central Washington. And ever since joining the team, I felt so welcomed and just extremely blessed of having this sense of belonging myself. So I just, thank you all for the opportunity, and I just look forward to working with each of you in some capacity.
And Veronica, if you want, you can put your email in the chat as well if anyone ever has any additional questions for Veronica. She's done an amazing job and really has jumped into this role right in the middle of summer when there's so many things going on and where half of us are out half the time due to summer vacation, and she was able to pick up and get rolling. I'm going to keep jumping in. I just wanted to give the board an update that we actually transitioned our HR firm this last month. So we are working with an independent consultant, Carrie Nelson, for our HR needs. We used to work for One Digital, or work with One Digital, which was a HR company on the west side. We were looking just really at what our needs were and what some of the service performance was with the previous contract, and this was just decided as the best transition for us. Where you guys will intersect with Carrie predominantly is she's going to be working with the executive committee on the executive director evaluation process, and she's going to be engaging in that with them in that work starting this month. So you'll see a little bit more information coming over the next few months on the evaluation process. And as I said before, we started the audit process with Dingus, Theropco, and Associates, and we just got all our initial paperwork in. We just got the questions and responses back, and Sarah Krauske will be jumping into that as well. So looking forward to looking and scared about our first audit, mostly because I just have never been through one, but Sarah continues to remind me that we are just fine and I shouldn't worry about it. Next slide. Another thing I just want to call out, June 9th, our team went and helped at the Molina Market, which is a food distribution day that Molina Healthcare put on. I want to give a huge shout out to Donnie Guerrero, who organized the event in our region, and I think I saw him running all around trying to take care of everything. So anyone who's ever done event planning before, really give him a pat on the back because he did an awesome job. And really just thanks to our whole team for coming out and doing it. This is a great way for us who are sometimes working really in that systems level and programmatic planning phase to get out there and directly work and interact with individuals that we are hoping to impact their lives. And so we as a team try to do this as a team building exercise once a quarter. We're hoping to try to get around to different areas as well as part of doing this, but it's really the concept of trying to get out there and serving the residents we are trying to impact, as well as spending time as a team doing more hands-on work. Next slide. Just a quick call out is that on September 18th and 19th, we're going to be holding a 2023 virtual care conference in Wenatchee. This is really an expansion and a conference focused around telehealth work. You can read the description on the PowerPoint right now as I'm chatting, but really we were able to have this opportunity because of the chart funds that we received through the Washington State Healthcare Authority. And I know Wendy has been envisioning a conference and wanting to do a conference, and so this helped us bolster it and helped us really do it in a larger fashion than we probably would have done initially. If you are interested in it, we can send the information and registration information out to everyone. Next slide. Few just quick statewide updates I want to keep in everyone's mind is we are currently going through Medicaid redetermination right now. That began April 1st of this year. So just as a reminder for everyone, with the end of the public health emergency, that required individuals who were kept on Medicaid during the public health emergency to go through redetermination and get determined if they still qualify. If they don't qualify, and they should go to another qualified health plan on the individual market, or if they already have employer coverage. We're anticipating across the state to see about a 15 to 20% decrease in Medicaid enrollment. So I know that our navigators out there, and Molly, I'm trying to see you on the screen again, has been working their tails off, trying to get in contact with individuals, get information up to date for them to make sure that they are going through the process to determine if they should be staying on Medicaid. I think this is significant because the 15% decrease is a large percent of individuals potentially losing insurance. And the more we can get out there to make sure that they don't have that gap in coverage and we can support them in any way which possible to transition where they need to go, the better. The other thing I want to call out is the state approved the 1332 waiver, or what is called immigrant health care. And so the focus of this is to create an insurance program for individuals who are undocumented in the state of Washington. We're one of the few states across the nation to do this work, and it's impressive to see it coming underway. The hope or the goal is January 1 of 2024 that they will have insurance plans available on the individual market for individuals. And then by July 1st of 2024, that they will have a Medicaid-like product that individuals are able to roll in. You'll see this information coming through over the course of the next 6 months, probably through your own personal channels. But again, it's as we are working to ensure that everyone has that basic need of health insurance coverage, these are great things to track to make sure that we're providing that information and connecting that information to the most appropriate people. And then directly related to us, June 30th, 2023, the Washington State Healthcare Authority had our waiver renewal approved. And so I'd like to say that you turn around and hit the ground running and you just jump right into the work, but that is not how it occurs. So we are really moving into the planning phase of this work. The Healthcare Authority has 6 months to get funding and process protocols approved that will dictate how we receive our funding, what are some of our deliverables as ACHs, and then once those are approved, we can move really into that next phase. So ACHs are working directly with the Healthcare Authority and other state partners to start getting these protocols developed. You'll see a lot, and I know our managed care partners on the team are actively involved in this work as well. And so we are going to all be actively working and planning, negotiating these protocols and getting this work moving forward. So more to come on that as well. If you go to the next slide. Just a few quick grant work call outs for our region. Just again, a reminder, I sent all the board an email around the chart funds that we are utilizing through the end of September as part of the chart alternative payment model coming to the end, but our region having some leftover funds we can expend. So really a lot of the funding for that work is around telehealth, digital navigation, and work we're also doing with mental health triage in the Okanagan County and Confluence Health. Really a lot of this work was work that we had developed as Thriving Together NCW that we could then utilize chart funds for, or work that we could expand upon that we could utilize chart funds for, because we had really 3 months to expend the funding. Another FYI for the board is we are working with the North Central Washington Tech Alliance to submit a Department of Commerce Digital Navigator grant that is due this Sunday, because the state decided to make the grant due on Sunday. I really want to give a call out. It's Summer Hess, who is an independent consultant, and Jenny from the NCW Tech Alliance has been doing the bulk of this grant writing. We are planning to be the lead applicant for it, and that was decided between the three of us because of our strong connection with health and well-being. We felt like we would be the most competitive for the region, but we're going to be leaning heavily on both NCW Tech and the partners to help really build this out in our region. Next slide. And then I really just have one quick partner update I wanted to call out. So if you go to the next slide. Just really a shout out. This last month, there was a group of 8 community members who went to the Parent Leadership Training Institute over in Everett to get trained up in leadership development. I know it says Parent Leadership Training Institute, but a lot of these skills are really leadership development for everyone involved. And this is really an initiative that's been born out of the Our Valley, Our Future, Many Voices, One Region Game Changer and Diverse Leadership Game Changer. And so they've been doing this work to look at how they build strong, diverse leaders in our region. And 8 individuals went out to get trained to bring that facilitation back to our region. You know, some of the things I've heard from partners is that working group that's involved in planning this out already has young, diverse leaders involved. So just the group of individuals that are getting involved in this work and engaging have a lot of enthusiasm and are continuing to build up leadership skills in our region. So the planning committee is even helping to achieve that. And the hope is that they can turn around and incorporate individuals to continue mentoring and building up additional leadership skills. This is a great way to look at how we build belonging and civic muscle into our region. And so as this gets rolled out, we'll hopefully come back and bring updates to everyone. Our primary role is that Mariah Kelly, our network coordinator, has been joining that work group and supporting development and bringing that connection back to us. And then we help support some of the scholarships out there. But really, I have to give it to everyone who's on this image and everyone who is on this PowerPoint. They were the ones that did all the work. And if you go to the next slide, I think I am done. Any questions? If none, you can always email me. I know the ED report is not that exciting. We will switch over, and Molly, I will turn it back to you.
All right, thank you. And up next on the agenda is a finance update with Sarah Krosky. But I do want to let everyone know that there's a separate attachment, the ED contract approval resolution from your packet. So that's what we'll be going over. And Sarah, take it away.
Yeah. So, hi, everybody. What this resolution is hoping to do is actually to combine a few. So when the original resolution came out of signers, it listed not just people's positions, but their names. And so the first part of the resolution that you see is just updating to the actual, if you scroll down, there we go, right there. The first part of this resolution has a lot of legalese in it. But what it is stating is that the signers on all financial institutions, regardless of what they are, would be the board chair, whoever that may be at any given time, the treasurer, the finance committee chair, and then the executive director. So the only real change here is that we removed people's names to allow for board transitions. Okay, and if you continue to scroll down, what we looked at doing was combining the budget resolution and the contracting resolution into all one space. And so what this does is it takes away the percentage in a budget spending policy and moves it into a more contract focused, right? If we take on chart revenue and it falls in over $1 million, it requires, hey, the board's going to come in and say, yep, we support this, right? If a grant comes in, right, again, because it's an aggregate of the total contract, comes in and it's only $500,000, regardless of how many years that is, the board's saying, we're okay with John signing this. We understand. We'll get it as part of the executive summary, right? So at no point, nobody doesn't know what's going on. This is just streamlining, getting contracts in and through the door. So part of approving the contract also means the spending of that money, right? So if we're a pass-through for a grant, we're going to get revenue in, but we're going to turn around and pay it out to partners, less our admin rate. So the final piece that I think is really important about this is it gives the finance committee specific place in this policy, right? So the old resolution, there wasn't a finance committee. So what this does is it gives a second step for the finance committee to do a double check, right? And that can be whether there's a variance in the budget, right? So we bring in chart, but we didn't know we were up for that. That's a variance in the financial statements. And it facilitates this collaboration and allows and empowers this committee to say, what's with that? And here's what I want you to do with it. Whether that be a budget amendment or an explanation, and or more importantly, hey, I think we need to take this contract in as part of the executive director's summary review and give it a chance for everyone to read, because maybe it's complicated, or maybe it's one time, maybe it's rolling. It allows the finance committee room to breathe. That's my really quick down and dirty summary of this resolution. Does anyone have any questions, because it's combining 3 resolutions?
I don't really think it's a question, but I do appreciate the fact that we are incorporating Thriving Together North Central Washington in such an important resolution document that it goes along with any grants that we would be submitting for. It kind of takes away that question that they have on what is our name and who are we. So I liked that. Timing was
Correct.
good.
Yeah. So a lot of this is just allows us to, so it's what the ultimate goal of this does is it actually reduces costs along the way, right? So if John knows he's going for a contract, he can already start prepping the board where it's at the finance committee. And then what it does is it actually reduces CLA expense along the way, because then the admin stuff is just taken care of as we go. So this is like our, I don't want to say it's our all-in-one combining grand poobah thing, but it kind of is.
I like
I
the
gotta
grand
laugh.
poobah thing. That's good.
I feel like if I can get one laugh out of a board member, I've just nailed it.
Yeah. What is it? Just I'm not sure what's the actual overhead expense that we take out of contracts for admin?
So we
what
defer to
percent of it?
10, we do 10%, the federal just given rate. Our goal is to
Yeah.
never be more than that if we can help it, which means controlling all costs along the way.
And I would say, Sarah, just for Dr. Chilby's knowledge, we haven't had in past contracts, especially since the waiver revenue was basically 99% of our revenue. We've never had that traditional overhead rate. We're anticipating we will get there. We want to make sure that we have that factored in. Even with the start contract, we have an overhead built in as a project management fee.
Good. Yeah.
So this is Carlene. I just want to state that, you know, again, the board is 100% fiscally responsible for this whole thing. And so I want to be really careful that we don't streamline things so much that the board and just a committee kind of oversees the nitty gritty. I know you guys haven't done that yet, and but I've been on boards that have, and I just really want to be careful that the board understands that they can say yay or nay to different contracts and different pieces here, and that maybe, you know, maybe 2 years down the road, somebody else steers us a different direction that we shouldn't be doing, for instance. And just want to make sure that the board always has that ability to understand and to vote and approve.
You are absolutely correct.
I guess my only question is, I don't see the whole of resolution 6.
Oh, you know, that is our fault. I do not think that got attached. Let me see if I can bring it up quickly.
Yeah, that was my only comment too, is that seeing the old language and having it to compare to the new with the strikeouts or whatever is definitely helpful when we do these kinds of changes. Same thing with bylaws, which I think we have in this document.
I'm gonna share screen.
Mm-hmm.
And if we're okay with it, I will just bring it up so you guys have an opportunity to read through it right now. If you have any, we can also send it out after the meeting to make sure you guys have a copy.
So I guess this kind of answers my question. If we, I mean, you're asking to dissolve resolution 6. But resolution 6 only talks about accepting contracts. It doesn't talk about spending authority, which is the first part of resolution 6. So where would that be addressed if resolution 6 was eliminated as a whole?
So the spending authority that goes into it is by everyone approving the contract. They also approve the expenditures that go towards that contract. So this would show up like as we do budget work, we would be able to show a variance and where those variances are. And those explanations would be part of your board packet in the financial piece, and it would also be touched on in the executive summary. Great question.
Is the language clear enough in here that it's not only approving a contract, which would be the receipt of funds, but also the expenditure of the contract? I'm not really, I guess that's the part where it's not really clear that the term, approval of contract includes both receipt and expenditure.
And that's something that we could bring, Sarah, we could bring back to legal just to confirm under review and make sure that gets called out.
Yep.
Prior to sending it out for signature, and we could approve the resolution with that modification in mind.
Yeah. So I'm wondering if maybe section 2, where it says the board hereby authorizes the following general guidelines for spending and contracting, we could probably maybe break that out into 2 sections, if I understand the feedback correctly.
Right, because I think when it says all contracts in aggregate of those various values, it's telling me that that's the revenue coming from a contract. That's how it reads for me, and I'm not sure if that's what and if it means both acceptance and spending. I mean, receipt and spend. Then it might be good to just have that really clear.
No, absolutely.
Yeah.
These are great
So
questions.
I need a little more clarity too, because a committee cannot approve on behalf of the board, correct? A finance committee cannot. So my question is, it on that second line in section 2 there.
So board approval. Yeah.
Yeah, it really, I mean, if we approve things to happen in that way, I mean, I just want to be really careful. We should not have any committee on their own approving anything directly.
Correct.
Correct.
So what the committee does is it's vetting the contract, and then those things roll into the consent agenda and part of the executive summary that then
that's
gets board
fine.
approval. No. You're asking a really good question, and if we need to clarify it better in here, I just want to make sure I make a note.
Yeah, you may just
I
want to
would
say
not
board
have any
approval.
committee doing discussion and approval, but they can do recommendation to the board and move it on
Right.
for consideration, right?
Mhm. And that would go for any amount, right? I mean, it could be part of a consent agenda, but at least it's been reviewed and then forwarded to the board for review and the consent agenda for approval.
And then sent.
And I'm looking at that under section 2, the 2 bullets. It could be brought to the attention of the finance committee for discussion and board approval,
Right.
or formal board approval, or something similar to that.
Peter, I see your hand up.
Yeah, I was going to say the same thing, that it be explicitly forwarded to the board for approval, and that could be done, through the consent agenda or not, but we have separate guidelines around what goes through the consent agenda. The other thing I was going to say is that it seems like it would be worthwhile putting another bullet in those 3 that explicitly talks about expenditure approval for items covered in the contract. That would make it really clear.
In
All right.
contracts. Sorry, I'm writing notes furiously. Apologize for the momentary silence.
Other comments or thoughts?
So
Great catches. Yeah, great catches, I think.
does the board understand here, though, that anything under $750,000 is under John's approval, and then anything over that would go to the board? Is that clearly understood by the board?
So that's the piece that I thought we were going to need to, that we should include, that all those expenditures need to be reviewed and at least approved, at least in the consent agenda, because that's a substantial amount of money. I mean, I've seen, boards will say 25,000 or less, or 10,000 or less goes automatic, for small contracts and for maintenance, or, things like that. But 750 is quite a bit.
Yeah, what I'm understanding, the intent of this is that a contract that we receive revenue for will have a budget attached to it. And so the budget has already been reviewed and approved by the board. And any deviation from that, as long as the total contract amount is under 750, any deviation from the approved budget for that contract doesn't require board approval or review, because it's already been approved by the board the first time it went through. Is that the flow that I'm sensing you're trying to do? Okay, and so
Yes.
okay, so like to Michael's point, then things like maintenance and things are not part of this because those are in operational budget that gets reviewed. But so is there a spending discrepancy limit on operational budget that's outside of contracted revenue? Or are we just assuming that all revenue coming in is operational, is contract? I mean, there's no other revenue, right?
Yeah, there's no other revenue.
So where do operational, I guess that comes in the main, so
We're going to do we do an annual budget. And so all of those specific things are addressed every year at the annual budget.
and then, then would fall under the bullet point of, so the total aggregate of our contract that we get from the HCA is over $1 million. And we generate a budget for that. And so any change from any deviation from the budget that the board has already approved would have to be brought forward for discussion and approval?
Yes.
Okay.
And Sarah, with the number of comments in here, I would probably recommend that we just pull this offline, make another.
Yeah, absolutely.
Some of that, and then we can bring it back to the board.
Absolutely.
Did the finance committee review this with you guys?
I believe we reviewed the bullets, but they didn't see the final resolution. Because we just got that back from legal on Friday.
All right. Well, I guess because my question would be, does the finance committee understand and agree bringing this to the board? But if they haven't had a chance to review it yet,
Yeah.
I think we may
Nope.
have kind of moved a bit too fast.
I'm looking,
I would agree. I would agree with that. I don't know, Rosalinda.
Yeah, I agree. I didn't see that it was an actual, is this considered the ED contract approval resolution? This is it. Oh, yeah, I didn't understand that we were taking action today.
okay,
But we
Yeah, and I
did
guess
approve
I
all
would-
these things in principle. We just didn't see the language
Yep.
per se until you did as well.
And I guess I would look at that total aggregate that can be approved by the executive director without board approval. Yeah, granted, I mean, if it's a deviation from budget, it seems like we still would want to have that reviewed and approved by the board so that it's not all landing on John's responsibility or whoever the executive director is at that point.
sure.
I mean, just to comment, you know, I'm a $50 million budget and I have a $250 limit.
Yeah, yeah, that's yeah.
$250,000, but still.
Mhm.
Sarah, do you have any questions you have back to the board based on feedback?
No, I think I've got my marching orders. I think they've given good feedback, and more importantly, it gives us a more solid wording that will allow us to be more congruent in the future.
Peter,
I guess this is a question for you, John. You know, given that, you know, you want to move as expeditiously as possible when contract opportunities come up, how much would this tie your hands if you had, you know, something that was important to get executed quickly and you needed another month before you could get board approval? I mean, we are a pass-through organization. We're funding a lot of organizations, and the intent was not to tie your hands unnecessarily. But I agree that, you know, big contracts, you know, should require some level of authorization from the board. I'm just wondering how this impacts you.
I think in general, depending on the limit set, as long as we have an appropriate limit, we'd probably run into, you know, half a dozen to a dozen times where we would come back to the board within a given year, and normally those would be contracts that we have about 2 to 3 months planning period for. We have a lot of contracts in like the $75,000 to $150,000 range that if we had to get approval on every one of those, that would be an administrative barrier. So we could probably, to Manuel's point, we could probably look at a lower range if that's what the board is encouraging. And still it increased the number that would have to come back, but most of those larger contracts are still multi-month planning contracts.
Mm-hmm. Yeah.
I do see this sometimes when we're working with partners and we're moving on projects, we can run into a crunch. So, would we ever be able to run into, because we meet every other month, right?
We meet every other month as a board and then monthly as a finance committee. But we can, what we can do is we'll make the adjustments. We can bring it back to the finance committee and then bring it back to the board for approval. And honestly, we just see. And we test it out and we see how it goes. And we revisit this next year to make sure that it's working, and we can discuss that at the finance committee and then determine if we need to bring any adjustments back to the board. You know, until we really get into it and test it a little bit, it's hard to tell if, you know, we are creating too much space for that or if we're too small for it.
Would you mind sending out resolution 6, or at least letting me know where I could find it, please?
Yep.
Thanks.
And I'm not sharing screen anymore, right?
No.
Perfect.
You were not.
All right, I think that covers this part, Molly.
Okay. All right, so we'll be looking for some additional information coming out from not only Sarah's side, but then the finance committee as well.
Mhm.
Okay. Thank you. All right. Up next, we have another Sarah. We have Sarah Bates on the governance update. And there are a couple of board decision forms that we will be reviewing and talking about next steps on how to get those approved. So there's some little bit of dancing we have to do in these. Thank you. Sarah?
Thanks, Molly. Yeah, so I'm going to refer you to your board packets on pages 10, starting page 10, through multiple pages there. So we also were kind of planning on voting on this today, but then after looking at the bylaw changes and some of the other things we want to change in the bylaws, we are putting off the actual vote until legal can take a look, maybe do some more legalese wordsmithing for us. And so please expect to see some actual voting opportunities, probably online between this meeting and the next. But the overall message for these decisions should be the same moving forward, as long as legal agrees. So the first change is to bylaw 3.3, and that's just the changing the board number back to the original 20 members instead of 21. That's like the big change for that one. And then bylaw 3.5, looking at how board membership composition and sector representation is considered. So this has really been the work of the governance committee over these past about 8 months. So just changing some of the language about how the board should be composed, basically reducing the number of requirements to allow more flexibility, more opportunities for partners outside of the typical healthcare, and looking more at the actual vital conditions partners. So the remaining requirements that we're looking at is to have 1 primary care provider, 1 behavioral health provider, 1 health plan, which is including but not limited to an MCO, 1 hospital or healthcare system, 1 local public health jurisdiction, 1 representative from the tribes, 1 representative, so from a local elected office and from a state elected office, so that's 2 total, and then 1 seat for each of the local coalitions for health improvement, so that's another 3. And then to kind of just make sure that there's good representation across sectors and across our geographic region, there's 2 additional requirements. So at least 50% of the primary decision-making body, aka the board, must be non-clinic, non-payer participants. and at least 20% of the board is representative of each local health jurisdiction service area. So that's where we are. And so you can look at the bylaws and you can see all the changes, things we've taken out, things that we've added. And while we say it's redlined, there's a lot of different colors because there's a couple of people working on this. And so you'll see both things that we've changed, but then also things that we've changed from each other. So just to be clear, some of those changes are original changes and some of those are changes that have happened between drafts. So that's the first board decision form. Yep, John.
Comment. I wanted to recognize that there was some back and forth discussion on those required seats. They were originally formed of the requirements that we had with the special terms and conditions for waiver 1.0. They are still clinical seats, but ultimately what we're still advocating for is more than half our board being non-clinical. So as the governance committee reviewed that in our last meeting, they still felt comfortable with the recommended seats and realizing that our ultimate goal is to ensure that more of our board is non-clinical than clinical.
Yeah. So it's really the ability to have flexibility that's been increased. So more at-large seats, less required, but that doesn't mean we don't want the same people that we currently have on the board going forward. So the next board decision form just looks at the fact that there's an opportunity for consolidating the nominating committee into the governance committee. And because the nominating committee is included in the bylaws, just making those changes necessary in order for that to happen. Also currently, the nominating committee consists of 2 board members, one of which is already on the governance committee. And hopefully the second nominating committee member will accept an invite to join the governance committee and therefore make that a fairly easy transition. The other changes are really reflecting the new suggested processes for recruiting, evaluating, and nominating prospective board members to really concentrate on looking at how we can best represent on our board our region and be that the diversity of both normal demographics, but then also our sectors and those who we feel like will best fill seats and skills needed for our board with added flexibility. So not too many changes. A lot of it is just word changing from the nominating committee to the governance committee. And yeah, those are the big changes. John, do you have any, or anyone on the governance committee have any feedback? And I suggest yes, just going through the bylaws, looking at those changes. And yeah, similar to what Rosalinda was saying with the finances, the fact is the governance committee will be making suggestions and recommendations, but it is still up to the board to approve new members to the board.
I'll defer first. I see Carlene and Manuel from the governance committee. I didn't know if you guys wanted to provide comments or insight.
Yeah, I just want to say in terms of the nominations, you know, we're going to process and recommend folks, but anyone on the board can bring folks to us to look at, or to even just directly nominate. There's always an option to be able to do that. So just want to make sure that it's a very open process, and very available to every single board member that would like to bring someone forward. And not just that, but we should require a little bit of that. So for everybody.
Thank you, Carly.
I'll just say I did receive some concern from Jesus Hernandez and Sheila out at Moses Lake about eliminating the specific call out for FQHC. And I reminded them that, that I told them that I was part of the governance committee, and I felt like this was a more modern approach to taking it, as opposed to calling out specific service lines, and really, pointed out that the designated board seats are a minimum, not a maximum. And so by eliminating the call out on specific service lines, it does give us more flexibility. I also think that at any given time, all three of us could sit on the board if they chose to. And the emphasis of this was wanting to have a board of people who wanted to be involved, not because they felt they had to be involved to fill a specific seat. Just my own comment, and John and Sarah, I just passed by my conversation. The point under additional board requirements of at least 50% of the primary decision-making body must be non-clinic, non-payer participants. Is that a requirement from the state, or is that something we put in? And I understand what we're trying to do. I think we may want to word it, because we don't want to limit, because what I'm seeing ourselves fall into is that we can't fill 20 seats. And if we had somebody from the healthcare wanting to join, but we can't fill kind of a non-clinical person beside it, then we would tell that person they can't sit on there. So I think there's a better way of wording that, just to avoid having it be 100% clinical without eliminating somebody who wants to participate, but we can't because we're already at the 50%.
Yeah, it was an original requirement that is being waived in the new waiver. So I think we could look at the wording of it. I agree, we want to emphasize one of our goals is to shift away being clinically focused as a board. So, but again, a lot of this shift is requiring us to be more intentional in our recruiting process to begin with. So it's on us to make sure that we are actively recruiting non-clinical people to do. So we can look at that manual and see if there's a better wording for it.
So this is Nancy. I would also say that being the representative from the Chelan Douglas Chai, I am not clinical. And so there are opportunities within there as well, where you'll have somebody on the board that is not in a clinical setting.
That's correct.
I think the other comment I would make from what Sarah shared too is just as we're reading through the bylaws, just with our transition over away from the health districts under Thriving Together, we just started to identify small things we wanted a little additional review on that wasn't even related to board composition. So that's also part of what we want to do, is make sure that legal has a chance to go through some of these more logistical changes and ensure that the bylaws are updated and meet those requirements.
And that being said, a lot of these changes also, not only are we lessening some of the requirements and adding flexibility, but also making sure that we don't have to come back every single year to update the bylaws because we're changing something slightly. So just being clear on that it also is, hopefully you'll have fewer bylaw changes year after year. Peter?
So the full board approves new members, right?
Correct.
So I'm on another board where, I think that's true for all boards. But in places where a lot of people know each other and have history, and not all of it's good, it's a little awkward when you get to the final vote and some board member, you've already vetted the person, you've already interviewed them, and they get, turned down. That's happened to us, and it was pretty embarrassing. I'm wondering if, I don't want us to get into the whole procedures but it would be nice to avoid that kind of situation.
Yeah, and I just also, Nicolette brought up a good question of like, do nominees have to be recommended by the board members, or can community members show interest? And we are looking at ways to open up an application process to the governance committee to allow for that, so that community members or community groups can help to bring new insight and new interests to our board also.
I think that's one of the beauties of having a nomination committee, is you can kind of feel when there's other people that have an issue. Then you can look into it a bit and have just some general eyes wide open, so you're not blindsided.
I guess my point was it'd be nice to have that happen earlier in the process rather than later.
Yeah, I mean, in my recommendation is always that you bring forth some names before the actual nomination, and then the nomination committee can look at those folks, and then that's my preference too, is a little more time around it.
Yeah, Peter, I appreciate that, and I agree with Carlene. I think that just making sure the board's aware of who's in the potential waiting to be a board member and interested, and then they can provide feedback to the governance committee. And part of the goal too is, as Manuel said, is also to ensure that intent isn't just a requirement, but a passion of the board member, so that we're not getting board members who just feel required to fulfill the duty.
Yeah, you could say no more than 10 clinical people, or 10 or less, or something like that.
So Molly, any
Yeah.
more? Let me ask that.
My concern is that now we have a resolution that we have deferred to the October meeting, and now these two other board decisions. Can we do some of these electronically prior to October? Normally at a retreat, we don't handle a whole lot of board business, but I mean, we would if we had to, but I just didn't know. I wanted to ask the question of an electronic voting possibly on some of this.
So our bylaws does allow for electronic voting. I know Sarah and I had a chance to talk, Sarah Bates, sorry, Sarah Krosky, I see you both shaking your heads. About the potential of moving it electronic, mainly because if we wait till October, we'd like to utilize the change to go recruiting. We'd like to utilize that change and engage the governance committee and the board in a recruiting process. If we feel like there's a lot of questions, we always have the option to call a special meeting to cover these two topics as well. And it could be a shorter meeting with the focus on that. So we have those two options, and we could determine which ones are required to get, or is okay to defer, and which one we need to move up. So I think
So
yeah, from the board.
Then I do ask the board to review these when they come, and if you have questions, and if you feel like it's something that can't be done electronically, please say so, and we can have an extra board meeting. But yeah, I just wanted to get that clear, and if you do have a voice, and we are not going to rush this at all. So, all right.
And Nanine, I would say, if there is a conflict, a board member can recuse themselves from the vote on a specific
Absolutely
individual. So, and that has occurred from time to time on different board motions. Teresa Atkinson.
So appreciate the dialogue, and of course it brings up other questions while we are reviewing this. So a couple things come to mind, like people with a passion wanting to come forward, and then there's very negative passion that could somebody trying to come onto a board in order to create harm for the organization. So being mindful, I don't know how we fine tune that, or lack of participation, having a board member that never attends the meeting, and does that give a committee or somebody the right to go ahead and replace that position if their attendance is, only 10% of the meetings or something like that. So since you're opening up, just a couple other thoughts.
Yeah, to be clear, the opening of a community-wide application, that would be done and vetted and considered by the governance committee before the board. It's recommended to the board, and so that there is a little bit of that stopgap to try and prevent any harm coming to the board. And then also there was something else. John?
Attendance.
Yes.
There is an attendance requirement, and I think with a more active governance committee, we could look at that. And honestly, I would say is if there's anyone who's managed a board that's had that adverse negative passion, I would love to have an individual conversation with you, because that really is a risk. And whether it's lessons learned or lessons on how to mitigate that, I think that would be important to figure out how we infuse that into our process.
And in terms of the attendance, so that would have to be dealt with outside of the governance committee, I believe, through probably the executive committee and the entire board having a vote to eliminate someone from the board. And so that would be only considered by the governance committee following an empty seat being open. So there wouldn't be voting on a seat that's filled currently.
Any other questions? And if you do, as you're reading through them, if there's anything you catch or any questions that come up, please turn back with Sarah and I, and we can also bring it back to the governance committee for further discussion. We have some time to work this out, but we're going to be actively moving this forward between now and October. So the sooner you can read through it and the more we can get this engaged on, the better. I will take you up on that, Peter. Thank you. Molly, I will turn it back over to you.
Thank you. Thank you. Good discussions. At this time, we have Wendy on telehealth updates. We will have a break after we have Wendy's presentation. So I just wanted to let you all know that.
Great. Thanks, Molly. Just checking to see you guys can hear me well. So just a little background before we get started. Since we have several new board members, a few years back, I'm so lost in time because of COVID, I have to admit, I believe it was 2021, possibly 2022. The board allocated $2 million to do some telehealth expansion. Prior to that, there was some allocations for an assessment. Several of our clinical organizations did the maturity assessment. We also had WSU who did more of a community assessment, which gave us some information, and we chose to continue to move on through implementation. With the implementation, we chose to hire Ingenium to roll that out both in the community and the clinical setting so that we can build the bridge. And the idea was that we would continue to optimize the clinical setting, help organizations build out their policies, build out their workflows, train their staff, and looking at different ways that they can utilize telehealth within their organizations from a clinical standpoint to be able to reach the patients. The flip side is how can you work with your community then to create access points within the community for patients to then connect into those clinical settings. And so that's what we've been working on, is this bridge, one from the one side and the other from the other side, and then starting to connect the two so that we can start to break down barriers of accessing telehealth from a social determinants of health side. So we've been working with Ingenium and their partners, Laurel Health Advisors, on an impact assessment as well. So we wanted to see what is it that we have done, where are we currently standing, and not just with the individual organizations that we have been funding, but as our region as a whole. So we've also reached out to organizations who aren't funded to look at what is the impact of telehealth in our region and what is it that we can do to continue to improve that. So today we've invited Ingenium and Laurel Health Advisors. So Ingenium, we have Christian and Kathy, and I'm not sure if Trevor's on the call or not. I don't see his picture as I look at my Brady Bunch. And Laurel Health Advisors, Yael Harris and Jason Goldwater. Thank you, Trevor, you are online. To present, I'm going to let them introduce themselves. They'll do a much better job as well. It's an hour. It seems like a long time, but it'll actually go by really quick. We'll have a presentation from Christian on the work that's been done with optimization, and then we'll have a presentation with Yael and Jason on the impact assessment and the results that they found. So you'll get both of those presentations, and then there'll be time at the end for questions and answers. I will defer to Christian and his team and Jason and Yael if they want to ask questions during their presentations or to reserve them for the end. I'll let them answer that as they introduce themselves. So to begin with, I'll turn it over to Christian to lead the way with introductions of your team.
Great, thank you so much, and thanks for having us back here. It's excited to be here and to report on the progress. And as Wendy said, it's been since 2021 since we've been working here in the region, and we're looking forward to continuing to see kind of the fruits of all the work that we've been doing here together with all the different organizations and everybody here. Oops, and I just lost there we go. And so my name is Chris Malastrom, the founder and CEO of Ingenium Digital Health Advisors, also here. And maybe Kathy, you can just briefly unmute yourselves, and Trevor, so that you pop on the screen and maybe you pop up to the top of the list of Zoom windows is Kathy Latender.
Hi, everyone. I'm Kathy Latender.
And we also have here Trevor Cunningham with us, who's been at us from the beginning here on this effort.
Hey, great to meet you all.
Good. And I'll be looking to Kathy and Trevor to see if there's any additional comments to add here to the slides. Feel free to ask any questions here in the chat. I'll be monitoring it. As Wendy said, I'll have a few slides to go over, and then I'll turn it over to Jason and Yael to talk about the impact assessment, specifically the baseline assessment. But we can take questions at the end. We can take questions before I hand things over. So really want to serve you, having access to us to ask any clarifying questions or make any additional comments that can help us. I started off with a timeline because, similar to Wendy, COVID threw also my memory in for a loop. We started here with telehealth services assessments in 2021, really looking at about a dozen of organizations to see how were they using and utilizing telehealth services, video visits, RPM programs, and the like, telehealth group visits. And so we've done an assessment there, and I have a little bit of a reminder update slide that we presented a while back. And then, as Wendy said, you allocated some funds to really make an impact in the region here to help with the clinical partners to optimize their telehealth use, to maybe pay for some equipment, to then also work with the schools and the libraries and maybe other community access points to bring better access to care to the residents of the 4-county region. And so that's the telehealth program optimization work that is currently ongoing. We also then first took out the time to work with NCESD 171, specifically Kathy Moret, who was on the board before, to develop a telehealth strategy for the schools in the region. And then we worked with the team at NCW Libraries, with Tim Dillman predominantly, but also Kim Nair, to develop a library-based teleservices strategy. So actually going beyond telehealth, which I'll also explain here in a minute. And then we kicked off earlier this year the work with Jason and Yael from Laurel Health Advisors to really do an impact assessment in 3 different stages. First, the baseline assessment, which Jason will talk about today, then an interim assessment to really see how much progress we've made, and then to guide kind of the last portion of the implementation, so that we can really achieve the outcomes that we were designed to achieve, and make some course correction or identify different focus areas. So we're looking forward to receiving that impact assessment later this year, early next year, to really look at what can we do differently to really make that impact on access to care and improving outcomes in the region. And then we had the good fortune of also John and Wendy and the whole team pulling together a grant application for an extra grant, which allowed us for additional funding, with a little caveat that we have to generate all the value by September 30th. Also an update on that, but this is really great because we now have, we provided all the infrastructure, all the elements in place, and now we actually got to build on that optimization and actually got to do some really cool things here that we've kicked off a few weeks ago and are now working tirelessly to really bring better, an additional set of services. I also have an example on that. So that's the roadmap here that I'll take you through in our presentation. Starting with the telehealth program assessment, we've leveraged a tool that we've developed a few years back of assessing organizations on the different levels of maturity, going from chaotic, where nobody knows what they're really doing, but everybody has a webcam and a Zoom license, to all the way where it's strategic and transformative, where organizations really are looking at leveraging telehealth, leveraging remote physiological monitoring, all the digital health innovation to bring care to the patients at a distance. So in everything in between. With no surprises here, you had some really great organizations that were at the strategic and integrated level. There were some organizations who definitely were interested in benefiting from more help that we've started working with. We also did, in the meantime, since our last report, 2 more assessments of 2 other organizations. And that's where they fall on the spectrum. And so really, we're excited to actually go back in the organizations that we've worked with and do a post-optimization assessment and see that the organizations we work with, we brought them to the integrated level, which is our goal, because it's the gateway to really looking at telehealth as a strategic tool to grow access to care, to grow the volume, and to attract providers and all of that. So it's becoming increasingly a strategic tool, which the organization that is at this level can assure you here. So then that was the vision statement and mission statement that was created and that we presented back here. Still retained the NCACH nomenclature here for historical purposes. So the mission is to improving health and wellness in the community through telehealth, so that every resident can access easily all the care they need, where they need it, when they need it, in all means, primary behavioral, dental, chronic, rehab, specialty care. So really, ultimately having an infrastructure where healthcare delivery organizations, as well as the libraries, as well as the schools, and maybe other community access points, will make it easy for residents to take care of their health, to get diagnosed, to get treated, to have preventative care. So that's really the vision. And again, we're wanting to have this baseline, interim, and final assessment to really look at that we're making sure that we're generating the biggest impact for the investment that you're making into telehealth optimization. As Wendy mentioned, I've mentioned multiple times, what's novel about this approach here, I think unique in the nation, is that we're not only improving the telehealth capabilities of the interested clinical partners with the FQHCs, behavioral health clinics, critical access hospitals, and rural health clinics, addiction treatment service providers, but we're also focusing on establishing a telehealth services in the communities, going through the schools as access points, the libraries, fire stations without an S there, and girls and boys clubs. So anything that pops up for the providers. And so that really is novel, that there's a systematic approach across the whole region versus one-off solutions between, let's say, a healthcare provider and a school, or between a behavioral health provider and a library, which is what we're seeing in other areas in the US. And so and we're obviously very optimistic that this will produce the impact that we're hoping, so which is why we're looking at that impact assessment. The approach that we're using is very comprehensive based on our experience in the telehealth, telemedicine field over many years. So we're helped all organizations that we're working with to establish their virtual care strategy, telehealth strategy, connected health strategy. Different organizations chose different names for it. But it all started with really engaging the leadership team, the clinical leadership, the executive leadership, and really establishing also a support structure that can help clinicians and staff to deliver telehealth powerfully. That means we need to have workflows and policies well-defined and trained on. We need to have the technology optimized and selected. Most organizations, we just kept them at the technology that they were using, but just optimizing use and the training. And then performance management, another leadership responsibility. How well is our telehealth service actually going? What's the utilization? Is it going up? Is it going down? What's the satisfaction level of patients, of clinicians? So really a systematic way for each organization to assess how well they're doing with telehealth and telemedicine. That all hinges on, ultimately, on the clinician engagement. Ultimately, it's the clinicians that need to decide whether telehealth is a right tool in the tool chest of a clinician to deliver care. And last but not least, we need to let people know that this is an option now internally as well as externally. So we're also working then with the leadership team and the governance team to establish an internal and external marketing strategy. So that's our approach. This is a snapshot from some updates that we are doing with steering teams, where we're tracking kind of the different lines here in the project management Gantt chart to just describe progress as we're moving through this over the course of multiple months to really make sure that we're hitting all these 7 elements of this approach. Switching gears now to the other side of that diagram of the multi-pronged approach, starting with the school and library strategy. Basically, there's 5 different themes that emerged. One, it was important for both NCESD as well as NCW libraries that our strategy prioritizes those schools and those regions in the area that have the highest needs. So in our prioritization efforts, given that there's limited amount of funds to roll it out to all the schools, so starting with some schools, where can we address the highest needs? And also that we're leveraging a systematic coordinated approach so that not each and every school figures out things on their own and what works for them, but through the continuity of working through us here, we're developing a playbook. We're developing the best practices of establishing school-based telehealth services, establishing the best moves to establish telehealth in a library. And there's nuances and differences given on the community and the dynamics or the staffing or the size of the school. And we're documenting all of that in a playbook so that when the funding that Thriving Together has provided reaches the end and we've rolled it out to, let's say, 10 or 12 different schools and libraries, then NCSD as well as NCW libraries have a playbook that they can use to then continue the rollout, leveraging the best practices that we've discovered and documented and followed during our rollout of this. So that's how we're doing that. And then the first step is to establish the access points, and then on top of the access points, then facilitate and project manage the launch of different services. So we're in the middle of that. We're looking at a number of schools and libraries to establish the access points. The equipment has been ordered, or in one case already received. It will be installed here within the next few weeks, and we'll be able to kick off behavioral health services in schools and in libraries here over the next couple of months. And then we're not going to stop there, but we're also going to want to make sure, similar to that performance management mindset that I described earlier, that we are continuing to optimize utilization. One of the things that we've seen as we've studied school-based and library-based services around the country is that it's a build it and they will come approach, or set it and forget it approach. And so we really want to leave both the leadership teams, both at NCSD and NCW libraries, with an easy to look at a dashboard where they can track utilization and intervene if utilization goes down or it doesn't go up. So obviously we'll be still involved here in the next months as we roll this out, so that we can identify best practices to increase utilization, because most of this is going to be a lack of awareness. So will be also included in this is raising the awareness in the communities as we're launching these telehealth services, especially when we're going into the public spaces like a library, to really let the community as a whole know that this is now something that the residents in the community can use to use video visits if they don't have the capability at home with their care providers. And so that is really the long-term vision, but this all also hinges on optimizing utilization by measuring utilization and then acting on the data. Good, and let me just see here, good. So the novel approach also here is that, as I said, we don't have just one health center, one behavioral health agencies establishing school-based behavioral health or library-based primary care services, but we're establishing a telehealth access points that is provider agnostic, meaning that we can have a clinical partner that offers behavioral health services, maybe at this school or library. And we have a second clinical partner that can, where patients can schedule also primary care video visits. And we could envision that we also have clinical partners that maybe that offer specialty care services, as well as then the first clinical partner could also maybe offer primary care services. So it's really, it's a shared resource. It's a, if you want to call it a video booth, we could call it like that, although it's not a booth in most cases, but it's an access point that is accessible through a shared resource. And so as we grow this, the bottleneck is to letting everybody know how to schedule this particular resource for a visit with a patient. But that is the idea. Our focus at this stage, anchored in both strategies, is that we're focusing on the regional providers here in the 4-county region, but we also know of patients, of students who are traveling long miles to Spokane or to Seattle to see a specialty care provider because they don't have the telehealth capabilities at home. And so these down the road may also provide additional opportunities to see a child psychologist or to see a pediatric cardiologist at specialty care providers outside of the area. So really, it's an investment in an infrastructure that helps to build access to care in the region. The schools, you're familiar with your map here. So there's the different about 29, 30 school districts and 150 schools. And where the technology we're installing is again, it's telehealth solution agnostic. So basically it's a computer, and whether we install Zoom in it or Doxy.me or CoView or other specialty care platforms, that can be installed on the computer. But it's not prescriptive, meaning a provider who wants to provide services to students or to patrons or residents in the area is not limited to using that technology. It's their technology that their clinicians are already used to. So a very pragmatic approach. Similar to the libraries, we have a lot of libraries, and between the libraries and school, we really are getting up into a lot of the different pockets where access to care is tricky and challenging, where the driving times to the nearest provider is difficult. And so that's where we're also prioritizing them on looking to establish access points to really address the highest needs first. But we're not stopping for libraries at telehealth services, but really looking at here the 7 vital conditions and looking at what other services that do patients or do residents need in order to maintain their wellness, to restore the wellness, to live well. And as we know, there are several factors that are impacting health. And so we've been looking, and this is just a brainstorm, to establish relationships with the social services agencies that are already set up to do a video visit, but residents in the area don't have access to it because they don't have the technology or digital literacy or the data plan to support it. And so here the idea is that you could schedule your visit at your local library in order to receive that social services, again, looking at the more comprehensive approach that Thriving Together has set forth in its vision to really improve health and wellness in the region. And just in case you were curious who's on our roadmap here, so these are the 6 schools that we're currently talking to in the first phase. So we're in Chelan, Douglas, and Grant County right now for the schools. And then we're also looking at libraries in Chelan and Okanagan County. So really covering a whole area here already in this first phase. There are some providers here that are already providing services to schools. So some of the schools are already served through primary care and behavioral health. And so we're just looking especially at those schools who would have a gap in access to care. And so I'm very excited about having some very rural ones with Waterville. I mean, everything's rural, but Waterville and Wilson Creek, I think, are a different level of rurality. And so very excited that we're having the superintendents being super excited to bring this particular service. And we're working with the counselors there. We're working with the school nurses through Kathy Moret to really build the buy-in in the organizations and helping them to make this as easy as possible, because schools and libraries are always very, very busy places. So we're optimizing it for their time as well. And then last slide here, before I hand it over to Jason, is just a sample of what that investment in the structure and in the telehealth optimization allowed us to pull together in a matter of a few weeks of really brainstorming together with the clinical partners that we've been working with for ideas on how we can improve, expand access to care through telehealth, which was kind of the defined scope of this expansion grant that we have access to through September 30th. One of the very obvious scenarios that we had talked about multiple times was converting no-shows and cancellations to video visits. If the no-show or cancellation is because somebody forgot or somebody doesn't have the time to travel, can we convert it into a telehealth visit? Multiple benefits there. We're looking on the behavioral health side on telecrisis, that is behavioral health services beamed into the emergency room to intervene in the case of a crisis, to make sure what is the best disposition for the patient in crisis. How can we best help this patient? So rather than having to travel to the ED, being able to do this remotely. Offering more substance use disorder treatment services to residents that would otherwise have to travel 45 minutes to an hour and a half to participate in group sessions, and then also looking at the outlying areas. How can we do remote intake services for one of the clinical partners we're working with? On the medical side, then we're looking also at remote physiological monitoring for chronic care management with one of the critical access hospitals. We're looking at inpatient telespecialty care, virtual therapy for inpatient care, as well as tele-addiction treatment services and for inpatients to get that started before they're being dismissed. So alcohol or substance use disorder treatment. So really looking at really leveraging this infrastructure and that expertise that these clinical partners have now gained to deliver care at a distance, to really leverage that to open up the services to more individuals and provide better care. And then on the other side here of the school-based and library-based, we're looking at telebehavior health to students in 3+ schools, tele-addiction treatment services in 1 to 2 schools, televisits to library in 1 to 2 libraries, and then also starting the process of telesocial services. And all of that we're working on, aiming for, not aiming for, but we will deliver all of these services by September 30th. And it's thanks to the investment in all the work that went beforehand in building the relationships that allowed us to really be confident that we can move this quickly to establish these types of services. So very, if I may say so, very rewarding engagement. So good. So here was our roadmap that I've talked about. And again, happy to answer any questions that come up here. And we also have some time for Q&A after Jason's presentation here. So worked on those 4 areas. And now it is my pleasure to hand it over here to Jason Goldwater and have him talk about the baseline assessment and the framework for advancing telehealth.
Right.
Gail, do you want to go ahead and go? Can everybody see the screen? I lose it.
I mean, I can share my screen once I figure out where the
Okay.
chair is. There it is.
Done.
I cannot share. I don't have permission. Sorry.
Okay, yeah, I just made co-host.
Thank you so much. All right. So hopefully you see my slides now.
Yep.
I am not going to put it in presentation mode because for some reason it likes to hear what I say and then type what I say at the bottom and everyone else sees it, which is a little embarrassing. So I will go through the slides and then I will turn it over to Jason. So Jason and I are, I'm the CEO, Jason's the president and CEO of Laurel Health Advisors, and Jenny was kind enough to bring us on this project to work with Wendy, and it's been a true pleasure to help understand the baseline of what's going on within the community so that we'll frame the next steps of our impact assessment. So going here. Just go this way. So the purpose was really twofold. One was to understand the use of potential for use of telehealth across the region. And then the other was also to develop a framework that would be used to inform an interim assessment moving forward of the progress being made based on the investments that Driving Together has been making in the community, as well as Ingenium's efforts that you just heard about. So we started with a set of research questions to guide the decision, to guide our focus. And we really wanted to understand why people used telehealth. What are they hoping to get out of telehealth? Or why are they not happy with telehealth? Why maybe they have started using telehealth, decide not to continue using it, or they've been trepidatious about beginning to use telehealth. We also want to understand how telehealth is being used. What are the conditions it's being used to treat? And then is it really being helpful? So effective in terms of better quality, in terms of meeting the patient's needs, in terms of care coordination. And then we wanted to be objective in terms of the costs. How is this impacting total costs? And that is cost to the patients and costs to providers and costs to the community and the insurers. And finally, to understand what the barriers and obstacles are so that Ingenium can shape their work around addressing this. So quickly of the methods, what we did was we got publicly available data that's out there, for example, the US Census and Washington Department of Health. We also were fortunate enough to have someone in the State Department of Health run us some data on your state's all-payer claims database, which gave us some rich data. We also, thanks to Wendy, identified over 30 stakeholders from across the community who spent, including some of you, so thank you, who spent time speaking with us and sharing their insights. So this included providers, payers, community-based organizations, and then the others category, as you can see, is quite diverse. So a lot of representation, a lot of perspectives, which were incredibly insightful. We also did a quick survey of some health systems to understand how they're using telehealth. Some of this had already been done by Ingenium, but a few had not responded. So we then reached out to those additional ones. And so we had a full cadre of everyone who's responded. And we also looked at what the literature is out there, especially as related to how do you assess the cost and the impact of telehealth. So this is a quick assessment of the availability of services in the county. This was done, basically, I looked at all the HRSA data for FQHCs. I looked at Washington State Department of Health for hospital data, and then a search of other sources such as behavioral health and individual provider websites, different health systems in the area. And so as you can see, there's quite a few FQHCs out there, but they're not evenly distributed. As far as behavioral health, there are no behavioral health clinics in Okanagan and Douglas. That's worth noting. And so it gives you kind of a perspective of what's available and what's not, based on what we could find. Now, behavioral health, I want to point out, these are not standalone clinics. So there may be some associated with the FQHCs that are not standalone, which is not, these are standalone clinics that are not affiliated with anything else. And these could be substance abuse clinics, et cetera. We also looked at what were the primary diagnoses. So for telehealth, we found the primary diagnoses were actually anticoagulant use, and then depression, stress, and general anxiety disorder, which is very close to, we see a lot of mental health across the nation. However, when you looked at the in-person visits, we saw something very different. We saw hypertension being the number one, then anticoagulants, so that fits there, but then diabetes, which was all the way down here, was the next. So we found some distinct differences, and that's worth noting because telehealth is not always the best fit for every single service. And so trying to understand, is telehealth being used for the right services? And if there are services that it could be used for, whether we should optimize their use. So let's look at the primary, let's go to the stakeholder feedback. So the key things is that stakeholders feel that telehealth has increased accessibility. It's also, they also said that adoption continues to remain a problem for a variety of reasons, whether it's broadband barriers, whether it's ownership of device, whether it's the cost of internet. Everyone really agreed that telehealth is well suited for behavioral health as well as chronic disease. Although some people said it's been a lifesaver if they have a chronic disease that they don't have to go to the specialist and travel to, for example, the cardiologist. There's been a lot of concern about the uncertainty of reimbursement. So providers have suggested that they'd like to make more investments in telehealth and expand their telehealth work, but they don't want to invest more in a platform if it's not going to be reimbursed, especially because a lot of providers are in community health centers where Medicaid reimbursement would be critical to their continued operations. Hybrid care, everyone seemed, that's what we call in-person and virtual, was really well welcomed. People thought it was an excellent way of combining that some visits need to be in person, but a lot of visits can be managed via telehealth. One example of that, people said maternal health care, that there's, a lot of challenges in terms of, especially if you're a high-risk pregnancy, getting to care, but being able to use telehealth when in between visits to track things and communicate with your provider is great, as well as after birth. Telehealth was a really wonderful in terms of postpartum depression, lactation consultant. So really supporting the community when they can't get up to specialists. They also talked about the need for more education. So education being people don't even realize telehealth is available in the community or what it can be used for. They're not aware their provider even offers telehealth. And then, of course, there's a lot of challenges such as digital literacy, not knowing how to use technology. And so that is a program that is already being spearheaded by Thriving Together to help really expand that work and increase digital navigation skills among individuals in the community. And they all agreed that telehealth had real potential to reduce health disparities, increasing access to a wide array of populations, everything from tribal community members to single parent households, to families on family assistance, medical assistance programs. And then what we did with the survey is we found that almost everyone said that they were using it for behavioral health unless they didn't offer behavioral health. So if behavioral health services were offered by this health system, they are using it for behavioral health, but they're also using it for specialty care. And a lot of them found that case management was a really valuable way of using telehealth. They told us about examples of better care coordination, better medication management, lower rates of no-shows. So a lot of value in using telehealth for disease management. But they did point out that a lot of patients use audio-only telehealth. The being is the either A, not having access to a digital device or a broadband, or not really being tech savvy. And this is actually a barrier for older adults because a lot of them still use flip phones. So even if you make audio-only telehealth available to them, they still don't have a way to connect to a telehealth visit, which is why the community-based situations that Christian described will be essential. And as I mentioned, the key barriers are actually having access to technology, and then connectivity, and then broadband availability. And it's worth noting that even in places, some areas, there was no cell phone connectivity. So that was a real barrier in that if you didn't have a form of transportation, you still had to get somewhere just to connect to a telehealth visit. And so we looked at what public transportation and other features were out there to help meet that need. And I'm going to turn this over to Jason now to discuss the impacts on cost and our final findings.
Good afternoon, everybody. It's great to be speaking with all of you and to see some of you again. As the IL mentioned earlier, my name is Jason Goldwater. I'm the President and Chief Operating Officer here at Laurel Health Advisors, and I was responsible for the somewhat, I guess, involved economic and quantitative analysis or as people like to refer to it, the not so sexy version of the baseline assessment. But what we did do is we looked at both the cost benefit and the cost effectiveness of telehealth services up to date, and then established a framework to continue the analysis as we move forward with the impact assessment. So the first part of this was the cost benefit of telehealth. And Yael and I have been involved with this work for a number of years, and we've done this not just here at Thriving Together, but we've also done it nationally. And we developed a framework and a methodology to be looking at cost benefits. And to do that, obviously, you have to break down what the cost and what the savings would be. So the costs that are generally associated with telehealth that we factored into our model are the cost of personnel, the physicians, the nurses, the nurse practitioners, and those that are maintaining the system. The cost of overall broadband services, which fortunately we were able to find in a number of sources throughout Washington State. The maintenance cost associated with telehealth equipment, and then the overall cost of operations. The savings that are attributable to telehealth, now taking into account that usually when you're evaluating the economics of telehealth, it's not really just a straight comparison between telehealth and in-person care. It really is, you're looking at the ability of telehealth to provide care where otherwise care would not have been provided. So because of that, you look in terms of savings at reduction in hospitalizations because somebody would be able to access care at a particular moment in time. Now, the literature throughout the years has really documented different percentages to be taken care of. And what that means is that when you factor in a model, people will look at a 50% reduction in hospitalizations, a 75% reduction, or so forth. In our model, we used a 10% reduction, which some people would say is low. But typically when we do this analysis, we look at the most conservative estimate possible, really to try to get an understanding of what those savings would be in a very objective and non-biased manner. We also look at reductions in travel, that obviously the use of telehealth means the patient does not have to travel to an in-person site, and then increase patient productivity. And what that means is a patient does not have to take time away from work. They do not have to leave their job for a prolonged period of time to be able to travel to go see a provider and then have to travel back. And for many of the individuals within the counties that we were studying, a lot of them have hourly wage-based jobs, so that would be a significant detriment to actually be looking for in-person services. So keeping that in mind, we factored all of these and looked at what the overall savings would be. Now, there's a lot of different elements that we could look at, but when Yael showed you where telehealth was being used the most in our initial analysis, we took those into account to figure out what the total savings would be in the different counties. And as you can see, when you're factoring in the savings from reduction in hospitalizations, reductions in travel, increased productivity, even by the counting the cost of telehealth, that the overall savings in the baseline assessment are fairly significant in the millions of dollars. This is not anything that is unusual. This is very similar to other findings that we have uncovered during our research, and it is predominant in areas in which there are large rural populations. In very close or in very dense population-centric areas, the savings would not be as realized as they are here. And that's largely because in-person providers are fairly not far away enough in which telehealth is a necessity. Telehealth at that point becomes more of a convenience. In areas that are generally very rural, telehealth becomes slightly more of a necessity, so the savings are more acutely realized. So in all of these, particularly in areas of heart disease, and especially in the areas of mental and behavioral health, you can see that the total cost savings is fairly significant, as well as hypertension, which is important as it's something telehealth is being used for rather frequently, because people that are often hypertensive, as many of you know, generally have other conditions that are being caused as a result of that hypertension. So being able to control that through the use of telehealth provides not just a financial benefit, but also a clinical one as well. So the cost effectiveness, so this is slightly a different approach. So what we look at cost effectiveness is, if you look at two ways of comparing care, which one leads to an outcome that is more effective overall? And the one that is not effective, how much does that have to be increased in order to reach that same outcome? Now, based on the information that we received through a lot of the stakeholder interviews, as well as just sort of the general trend of the field at the moment, is that many people are now considering telehealth to be incorporated with in-person care and formulating a hybrid model. So that is, telehealth is used as an adjunct to in-person care. It doesn't replace in-person care, it was never intended to, but it is part of the ability to receive care in addition to in-person visits, which are essential. So we looked at two specific areas in which we were able to gather quite a bit of pricing information from Washington State. And we looked at people that have co-occurring conditions. So the first one was diabetes and major depressive disorder. This is also pretty common, that people that generally have a chronic disease overall also have generally some mental health issue going as well. And then the other one was looking at substance use disorder as well as co-occurring serious mental illness. And serious mental illness is generally defined as a type 1 access mental health disorder. So schizophrenia, bipolar disorder, major depressive disorder, etc. And when we factored this in, you can see that in-person care generally costs more overall. But what was more important is that in both of these cases, the quality adjusted life years, which is how much would an individual's life be extended if they were to use a hybrid form of care or in-person care, and how much would that cost to have an equal effect? In both of these cases, the quality adjusted life years was pretty much the same. There are some differences, but we would consider these to be marginal. However, what is critical to look at is that in both of those cases, it costs slightly more for an in-person visit to reach that same outcome. So even though the quality adjusted life years are fairly similar, in-person care costs slightly more to reach that same level. The last one we looked at was critical care and teleneonatology, also something that is very predominant, particularly in rural areas. And what we looked at is the ability to be leveraging telehealth in an inpatient setting to access a neurologist or a neonatologist rather, to be able to provide a consult to determine the next step, rather than immediately going to an emergency room and receiving care that way, or being transferred to some place to be able to provide critical care because they were unable to do triage in the beginning. And what you can see here is that doing a teleneonatal consult is significantly cheaper than it would be for the standard of care, and that the incremental value to achieve that same outcome really is significant. So we found really that the use of hybrid or in-person care is pretty similar with these co-occurring conditions, with the exception that in-person care costs slightly more. But when it came to neonatology, the significance was fairly acute. So that leaves us to our recommendations. So some of the key recommendations that we really were able to gather through all of this analysis, both qualitative and quantitative, is really to enhance outreach and communication between patients and providers, to educate and train both providers and patients on telehealth to increase acceptance and consistent use, to develop a telehealth services map to help patients locate where they can access telehealth services, to establish partnerships with outside entities that would help support adoption, and then really to use the data to drive adoption by targeting specific patient groups, really showing people if they have substance use disorder and they're struggling with mental illness, where the benefits of telehealth may be. Next slide. Other recommendations to educate health insurers on the impact of high copayments, ensure outreach efforts, demystify telehealth. I would say that's something that's been pretty consistent over the last few years. One of my favorite quotes, and Christian and Kathy both know this, is that I often say telehealth is not a unicorn, that a unicorn is a mythical creature. I'm sorry if that disappoint some people, but it isn't real. So telehealth is not some fantastical form of care. It is healthcare just delivered through another medium. Again, encouraging patients to request telehealth if it's appropriate and convenient, offer support to providers new or with limited experience using telehealth. For data use, really to understand the impact of telehealth economically and socially and clinically, is to leverage data from managed care organizations or use EHR data to target technical assistance. For policy changes, to establish permanent reimbursement parity between in-person and telehealth, to give higher reimbursement for rural health clinics, that telehealth can be provided to patients in non-medical locations. Right now, that's temporary because of the public health emergency. To provide reimbursement for audio-only telehealth, to make community-based investments, which is already happening, but to expand that. Understand that there are privacy issues, particularly when it comes to mental and behavioral health, but understand that you can create a HIPAA-compliant private engagement, but also make it accessible. And then, of course, cross-state licensure, particularly with individuals that would be able to provide services to Washington State, particularly within your region, if they had the ability to practice without hesitation or limitation, rather. In terms of ad hoc recommendations, partner with outside health entities that can address provider shortages, use telehealth to help providers meet educational requirements through continuing medical education, increase provider skills, and reduce costly transfers by facilitating telehealth adoption in long-term care as well as correctional facilities. Next slide. So the interim assessment is what's next. We'll start working on that, and hopefully we'll have some results to share by the end of the year, and we'll finish it by early next year. But that's really to understand how telehealth implementation and utilization affect access to care. How does telehealth affect clinical outcomes? Will telehealth reduce health disparities and increase access for underserved populations? And then can the use of telehealth in value-based programs lead to sufficient savings to incentivize and accelerate innovation? And again, Yael and I have worked in all of these areas. So we have done analysis, we have models, we're just working on gathering the data to really objectively understand what telehealth can, and honestly, what it will not be able to do, but would be able to address these questions and provide greater insight to help guide you further into the future. Next slide. So I thank you all very much for the time. I'll echo Yael's sentiments. We both are very grateful to Christian, Trevor, and Kathy for the opportunity to work with you. And we are just thrilled and very honored to be part of this project. We've been involved in rural health for 4 decades amongst the two of us. So this project is really plays to our passion and plays to the things that we care most importantly about. So we're grateful for the opportunity. Thank you all very much.
Thank you, Jason, Yael, and Christian. I'd just like to open it up and see if there's any questions or comments that anyone would like to make.
Yeah, thanks for that presentation. I was just going to comment on, it's really poignant to me about how the current fee-for-service, compensation or payment models that we're stuck in right now really inhibits this progression. Because every time I talk to providers about doing telephone visits, they say, well, we only get paid $14 through a telephone visit. Or if they can't get the video to work on a video call, they don't want to do the call because it ends up not being reimbursed at anything but a phone visit. And that whole reimbursement thing is really a major issue. So it's in systems that are fully capitated, there's a ton of telehealth incentive to do there because of that. So part of this policy work that needs to get done is to continue to move, especially primary care services, into some form of capitation. And some states are moving ahead pretty well with that, and other ones are just moving more slowly. And now that we have the new Medicare MCP program available in Washington State, the broader we can get that within our region into different health systems, the more likely we're going to be able to see a lot more incentive to do telehealth, because it will no longer be a fee-for-service reimbursement in the long run for that.
Yeah, thank you, Michael. A couple comments on that. So definitely agree with you. If we can just move everything to capitated care, to just value-based care, then it doesn't matter, right? I can send a patient a text message. I can give them a call on the evening, and I don't have to worry about whether to get reimbursed because I'm just trying there to help the patient to get better. Obviously, the situation, is not good when you have to switch to the phone because phone is reimbursed at the dismal levels that you described, which is what in our optimization work, we're really helping to set up some processes where the patient actually can be trained or validated, verified before you even jump on a call, so that it's not the clinician that needs to do the technical troubleshooting, but that it's really taken care of beforehand, before a visit is even scheduled. But the situation is, and I just want to bring that to everybody's attention, is really dire when it comes to FQHCs or the rural health clinics, because their reimbursement is lower than the standard rate you get for in-person care. Now, it's still better than not having a patient at all in the office, but still the discrepancy of that rate when everything else, Medicare, Medicaid, as well as private insurers are reimbursed at parity. So in most of the rest of the clinical world, everybody gets paid the same rate for a video visit that they would get paid for an in-person visit. And that's true across Medicare, Medicaid. It is not true for the FQHC world, and it's not true for the rural health clinic world. And some actually providers in the region have opted out of getting involved in this because the discrepancy of their standard rate and the telehealth rate is like 30%, 25% of what they are getting. And so they say it's not worth our effort to invest in that. So that's a loophole that really needs to be fixed because it's nowhere else existent in most states, and it's definitely not in Washington State, that you don't get paid at parity for a high quality video visit.
If I could just add to that, one of the interviewees told us, he's a rural health clinic. He said, we don't even offer that because if we offer telehealth, we would no longer be in business and couldn't support anyone. So it's just kind of compounding what Christian just said.
We're probably talking about the same person, yes.
Yeah, it's true.
Peter, you have your hand up. You're muted.
I'm a big fan of telehealth, and I'm part of a system that uses it extensively, but I must say I've always looked at it as a patient satisfier and access, by improving access without travel. And I was impressed by the numbers that you showed on cost savings, but I'm wondering if you can point us to major studies that have demonstrated those kinds of cost savings, broadly over time and over systems. I mean, there must be stuff out there that that demonstrate that. I mean, it must have been heavily studied.
So there are a number of studies over the last several years that have been taken this similar approach in really analyzing costs. They're very localized, so they looked at parts of West Virginia was one, some parts of Northern California was another one. I am certainly not one to be advertising myself as those that know me know well. But our study, that was a national study on cost benefit, will hopefully be coming out at the end of the year. So that would be one you certainly can look at. If I can get a preprint of that, I will send that to you, Peter, which will show you how we sort of looked at that globally over 1.5 million encounters that were done nationally. But the studies really incorporate sort of the savings to the patient, but also the savings to the provider, and ultimately what the savings to the system would be when you account for not having as many hospitalizations because care is provided, when you're having consults done on an inpatient unit before instigating a standard of care that might not be necessary, and understanding sort of how to be providing care through telehealth and creating actionable information so that then what to do next often leads to fairly significant savings.
Thank you. Senator Warren, you have your hand up.
Yes, I did. And I appreciate the conversation. Well, first of all, I appreciate the presentation. I remember when we first started talking about this concept in the legislature, it was before COVID. And we realize with COVID how important telehealth is. But there was a conversation in the chat about privacy. And that would be my biggest concern, especially with mental health treatments or mental health interactions. I've been to the Royal City Library. It's a very small library. Some of the schools, if they don't have areas that a student could be private to talk about different issues, that's what I would be very, very concerned about too. I think we'd have to build in some infrastructure dollars into this idea so that people can have, especially students and people who have mental health issues, can have privacy. So
yeah, definitely the risk of being overheard or even just being able to set foot in a library, right? So obviously that's the other thing is we're very cautious about not just touting it as a behavioral health access point. So no, this is a system where you can get teleservices, and we'll just leave it at that. And then we can say, well, and we're launching here with one behavioral health providers, right? So that it's not obvious. So that's the one aspect. And definitely we ran into, we're actually one library we're looking at, we're looking at some challenges with sound insulation, and we're experimenting, and again, behavioral health practices have known that for a long time. You can hear conversations in the hallway, and so they have sound machines. So we're definitely making sure that the privacy is protected. In the schools, we have a lot of the schools actually have, and some have lost that ability to have an in-person counselor that comes there once a week and then meets with students. And the schools are already so great in protecting the privacy of their students. So right, so they're not going to say, please come to the office for your medical visit, right? They say, come to the office. There's a call for you or something like that. They have some shorthand, and then so that's So we're very conscious about making sure that the privacy is protected, and doing that. The beauty, just one more comment here, is that with the age of consent of being 13 in Washington State, right, it allows some middle and high school students to really access behavioral health services that otherwise they would not be able to access because of family circumstances not really endorsing or supporting access to mental health services. So I think a lot of the counselors, school counselors we talked about, were very excited about just having this opportunity to offer a really private way for them to get access to counseling services. And so I think will be a great kind of side effect and benefit from that as well.
And Senator Warnick, I would also add that it was in the chat, the libraries have received funding, and they're doing some renovations in, I think, all of their libraries, and so some will be building out spaces. There's also a USDA grant, and the Department of Commerce works with this around the state also for the distant learning and telemedicine grant. We're looking for it to come open. We were not prepared this last round just because of where we were currently at and the timing of it, but we are prepared for the next time. That will also, this particular grant allows for the infrastructure building, including fiber and routing and that to help organizations build out there for distant learning and telemedicine. So it could benefit in various ways. Marissa, I see you have your hand up.
Yeah, thanks, Wendy. Marissa Ingalls from Coordinated Care, for folks who have not had the pleasure of meeting. Wendy and I certainly have had lots of conversations on telehealth, and I appreciate being looped into the assessment that was just reviewed for you all. I wanted to circle back to the comments around payment parity. Part of my regular duties as assigned for coordinated care are to work with the legislature, and I also co-lead our internal telehealth efforts along with our medical chief medical officer. But just to note that the legislation around payment parity, when the audio-only telemedicine payment parity bill was passed in 2021, there was a section in that was specific to rural health clinics. And I will read you one sentence from there that may be of interest. Which says the rules shall require rural health clinics to be reimbursed for audio-only telemedicine at the rural health clinic encounter rate. I am not familiar with, and this is particular for fee-for-service reimbursement. I am not familiar with any similar language for video visits, although it does sound like there may be some other issues happening based on comments there, but there is specific language that was added to audio only that is likely of interest to this group. And so I wanted to raise that for your attention. I am not sure where that language originated from. I was deeply involved for the health carriers in negotiating that bill, and it did not come from us. So I am not sure where it originated from, but that would be a conversation for Representative Richelli. He is now the House Healthcare Committee Chair and also very interested in telehealth issues. He was one of the sponsors of the audio only bill that passed in 2021.
Great, thank you for that intelligence. Very, very helpful. So again, I'm not a clinician, but again, I always have learned that video visits are preferable over audio only. But if you can generate more revenue with audio only, then that's an interesting incentive. So definitely want to look at that language and see if that can help at least to get started, and hopefully we can find similar language around video care, video visits as well. So, but thank you for that. We'll do some digging and do some outreach here with Wendy.
Yes, thank you. And Martha, I will reach out to Representative Richelli. We invited him to speak at the conference and he's unavailable, so Representative Schmick will be presenting. So I can touch base with either one of them. I believe he's the minority leader. Correct me if I'm wrong on that committee. So I'll reach out to them both to get further information on that and how we can better inform ourselves as well as our clinics on this reimbursement. Any other comments, questions?
Actually, this is Nancy Spurgeon. So I appreciate Senator Warnick's comments about maybe having to find some extra funding for infrastructure. And I happen to be a board member of the North Central Washington Libraries. And although there is the opportunity of the funding that it currently has to be able to design and do some better things in all the libraries, like all of those types of funds, when they were given to the libraries, and now when the libraries are in a place and a place to spend them, construction costs, all of those things have continued to rise. And so the dollars they have are getting stretched farther and farther. So I'm not trying to say we shouldn't do this, because I think it's a great project for the libraries and for our communities and telehealth, but it is something that still needs to be on the table as far as, you know, how far we can stretch dollars.
And
Absolutely.
definitely
That's why we also we're also looking at the other DLT grant, and that we don't expect that the library funding that they received would be the sole funding source for that.
Right.
And they have other priorities for funding too.
Right.
And the other thing we're doing here, these proof of concept launches, we're demonstrating in the libraries that have a designated room that can be utilized. We're demonstrating the value of this, which would make any grant application for additional funding for that equipment easier, because we have an example to point to how this can make a difference in the community. And so, yes, we're optimizing right now for where the needs are, where the interest of the library lies. To be engaged, because it's a change management effort, but then also looking at the infrastructure. But that's exactly right. These are demonstration projects that, through the measurement of the utilization, will be able to demonstrate the value of implementing such a solution, which then will hopefully give us better access to additional funding to build out the infrastructure that's needed to do telehealth in a private space.
Thank you. I'm recognizing we are 7 minutes over. I apologize for the agenda police out there. If there are any other questions, just want to open it one more time just in case. All right. Thank you, Christian, Kathy, Trevor, Yael, and Jason. I appreciate your time and everything that you've put into this, and look forward to our continued progress.
Thanks, Wendy.
Thank you very much.
Thank you.
Our pleasure.
Bye-bye.
Molly, I'll turn it back to you.
Thank you. Now, I did promise everyone a break when Wendy was finished, so we'll try and get back by 25 after to get going on our vital conditions. We'll be reviewing another vital condition up next. So 3:25.
But I say we jump into it.
All right, and vital conditions, which I love to review. This one's on transportation.
Yeah, I'm gonna jump in here. I'll make
Thank
it
you.
super quick. Yep, since we're running short on time. This information is in the packet that you all received. It's the last 2 pages, I think, 2 or 3 pages. So just encourage you all to continue to review those. And reliable transportation, as we know, everyone needs transportation to move consistently and safely between the many places that we must be throughout our day-to-day schedule. So work, home, school, etc. And we also know that transportation options influence an individual's access to jobs and social mobility. And in the United States, our primary mode of transportation is personal vehicles. And that is something that our infrastructure is really set up for. You can see on the slide there that 32% of the population does not have a driver's license. 45% of the population does not have access to public transportation, and 86% of the population in rural areas lacks adequate access. So it's really important when people have, reliable transportation. It really has a ripple effect through these other different vital conditions and really helps them able to kind of do their day-to-day tasks. And just the last note on reliable transportation, some ways that we can ensure a positive legacy moving forward are investing in public transportation systems that are really designed to support, walkable cities, bike trails, things like that. And then, investing in smart public transportation, and then also in infrastructure that improves walkability and other transit options. All right, if you could, perfect. And then the next one is the basic needs for health and safety. So it's this idea that, of course, none of us can reach our full potential in the absence of these, basic needs like clean water, nutritious food, fresh air, access to healthcare services, things of that nature. So when these needs are not met, there are a variety of immediate and then long-term consequences. So an immediate example would be hunger, sleep quality, reduced mental capacity, and then long-term, when basic needs are not met, we see things like chronic disease, mental health problems, inability to fight infection, and things of that nature. So ensuring a positive legacy means doing things like eliminating food hunger and insecurity, and then making transformations to healthcare systems, breaking cycles of intergenerational poverty, and things of that nature. So that was just my really quick review. And as I said, that's all included in the packet in more detail for all of you.
And Morgan, just to share on that, our goal is really just to share a little bit about each vital condition, each board meeting, just to kind of keep it in the top of all board members' minds, since we've adopted vital conditions as a framework, and trying to tie it to partner spotlights as well, which the last vital condition ties more to the work of the Hope Squad. So I think I'll turn it over to Mariah for that.
Thank you, John. And I am going to turn it over from here. We have Alyssa Polson joining us today to give the annual update for Hope Squad. So let me get those slides ready. And Alyssa, you can go ahead and introduce yourself.
Thanks, Mariah. For those of you that don't know me, my name is Alyssa Polson. I am the North Central Washington Regional Hope Squad Coordinator. So I help oversee all of our schools that are implementing Hope Squad across the North Central Washington region. You can go to the next slide, please. So those of you that may not be familiar or maybe new, I just wanted to give a quick overview of Hope Squad. Hope Squad is our peer-to-peer suicide prevention program. It is based out of Provo, Utah, and was founded by a school principal back in the early 2000s. Here in North Central Washington, I was hired on in May of 2021. So through the spring and summer, I was trying to find schools to get schools onboarded that may be interested in implementing Hope Squad. And then those schools then started in the fall of 2021. During that first year, because it was a brand new program, and I was also learning along with our schools, we ran into a lot of different challenges and learning curves, and coming right out of COVID, some schools having some staffing issues and things like that. So at the start of the year, we started with 15 schools that were signed up and 10 were actively implementing. And then at the end of the school year of that 2021-22 school year, we ended with 34 schools that were signed up for Hope Squad and 15 schools that were actively implementing. Like I said, we did lose some schools due to COVID and staffing, but Hope Squad is a very flexible program, but those schools just had decided that it was best to wait until they were kind of on their feet again and more stable. So next slide. So for year two, that 2021 was year one, and then this year is year two, so the 2022-23 school year. We started the year with 15 schools actively implementing at the start of the year. And then in January, we actually opened up Hope Squad to our elementary schools. It does look a little different as far as the curriculum goes and different things that they focus on in the elementary. But as a total, we added 8 new schools, which included 5 elementary schools and 3 middle schools. We did have 2 elementary schools that were implementing prior to the open registration. So that helped total our elementary schools at 7 schools. And then we have a total of 14 middle schools and junior highs and 9 high schools. Because we are region-wide, I wanted to break it down by county as well. So we do have 9 schools implementing in Chelan County, 10 schools in Douglas County, 6 schools in Grant County, and 5 schools in Okanogan County. Next slide. So I just wanted to go over kind of what we see as actively implementing. Just for a brief overview, we do at Together for Youth have a application process for our local schools. So once a school decides that they want to implement Hope Squad, they will fill out that application and then send it back to me. And then from there, on the application, there's actually a spot where they can identify 2 to 3 advisors to help facilitate Hope Squad. And then those will be those advisors can be any staff member in the school. So they can be teachers, coaches, administrators, any staff member in the school. So once those are identified, then they will turn in a principal agreement and affiliation agreement directly to the Hope Squad home office. And these are just, it's just a way for our schools to make sure that we're in compliant with Hope Squad, as well as having the support of the administration, being the principal in the school. Once those are turned in, then our advisors will do a online self-paced training. It takes about 6 hours in total. And they also do a QPR training, which is the suicide prevention model that Hope Squad uses. And if you're not familiar, it stands for question, persuade, and refer. After those are complete, then they go on to the student nomination. This is where the peer-to-peer support comes in. So each student in the school will be given a form with 3 different lines where they can fill in a student's name, where they see that student as trustworthy, somebody that doesn't bully, somebody that's easy to talk to. And that's just kind of the criteria that Hope Squad uses for those student nominations. And what's interesting about this nomination process is once all the nominations are turned in, the same names will show up on these nomination forms, which is how the advisors help select, or it helps the advisors select the students that will be the Hope Squad members. They do have the option to say yes or no, whether they want to be a part of that program. And if they do say yes, then they do need parent permission as well, so that they're supported in all aspects, both school and home. Each school will facilitate a parent meeting, and this is just an opportunity, number one, to get those parent permission forms signed, because that is a requirement by Hope Squad to have those parent permissions. And it's an opportunity for parents to ask questions and really gain insight on what Hope Squad is, what the responsibility of their student is. Once all of those are complete, then our squads are able to meet with their Hope Squad members. They'll go through the curriculum, and the requirement is that they meet at least once a month. Some of our schools have done it a little different, and it is easier to do it as a class. So they meet once a week. Some of our squads meet during lunchtime or during an advisory or homeroom, but they are able to meet at least once a month to get that curriculum.
Alyssa, I do see that Ray has his hand raised, so if you wanted to ask your question, Ray.
I can wait till Alyssa's end of Alyssa's presentation.
Okay, I wanted to make sure you didn't lose your question.
Okay, so like I said before, the Hope Squad curriculum is a little different for the elementary versus the middle school and high school. Hope Squad does really emphasize that they are a suicide prevention program. However, in the elementary, they do have a big emphasis on bullying prevention and how to help other students that may be struggling. The elementary does have more literature based, so they go through a lot of books, whether that's on YouTube and they kind of go through it on there, or hard copies. And some of the topics in the elementary include resilience, how to help a friend. They do have a portion on substance use and how to say no. Setting boundaries is a big one, and inclusivity, self-care, and bullying. And then in the middle school and high school, they do have the emphasis on suicide prevention, and they really focus on challenging students outside of their Hope Squad group. So each lesson in the curriculum does have an activity portion, and they will challenge the students, whether that's in their group or in their sports team or at home or for the community, some way to really spread that suicide prevention awareness. They do have more school-wide participations and activities, and everything is there on the Hope Squad site for advisors to really help that participation for other students that may not be in Hope Squad. And then the topics for the middle school and high school include adversity, inclusivity, resilience, self-care, and suicide prevention. Hope Squad really focuses on self-care, and they have a huge emphasis because they know that students do have a hard time. So if they're not taking care of themselves and they're not in a good place, then they're going to have a really hard time helping others. So they really focus on self-care and what that does to help your mental health before you help others. Okay, so Hope Squad is an evidence-based program. They are partnered with BYU out of Provo, Utah, to conduct and review reports based on a couple surveys. So they have a pre and post survey that's the Hope Squad students do at the beginning of the year and the end of the year. And with the BYU reports, they do it on a national level. However, you can ask for the data for your specific school or region, whatever your criteria is. I do get these results back from Hope Squad after BYU has reviewed them for our region. And then I go through them and kind of see where we're at. So for our region, for the pre-surveys, we had a total of 198 responses from our schools in North Central Washington. The elementary survey is a 20 question survey. We had 14 responses from those surveys. And then the secondary, which is our middle schools and high schools, is a 50 question survey, and we had 184 responses. For the post survey, I was actually able to set some time aside at our regional conference for our students to be able to do that. Most kids had a phone, however, there were some that didn't, so they weren't able to do the post survey at the conference, which could have been part of the post survey response. We did have less post survey responses. We did have a total of 172, and this was just for our middle schools and high schools. There were no responses for the elementary this year. But I did talk to the Hope Squad home office a little bit about that, and they told me that historically, the post surveys are known to have lower responses because of end of the year activities and sports and attendance. But I thought it was interesting. I just wanted to go through this really quick, that after I reviewed the data, there was a 20% increase in knowledge and persuading somebody to get help based off of these surveys. Okay, so our student referral data, we do call it the data collection form, but really this form is just based on our referrals that go through the advisor. They are submitted by our advisors through the Hope Squad online portal that they have access to. And we try to really encourage our advisors to submit these forms for any student that was referred for suicide risk. The results that I have it's only for the results that were submitted through Hope Squad. There may be other referrals that weren't reported, but this is just the information that I will have. So the questions do include the student's grade, gender, race and ethnicity, how the student was referred, the nature of their suicide, whether that student has had a previous suicide attempt, whether the student has previous trauma or suicide risk factors, and what the student's disposition was when the student left the advisor's office. Most of these students that are referred do end up going to some sort of counseling, whether that's through their school or through their medical facility. For a little comparison, in our 2021-22 school year, there was a total of 17 student referrals from 3 different schools, including Pateros, Okanagan Middle School and High School, and Orondo. For this year, for the 2022-23 school year, there was a total of 55 referrals from 8 different schools, including Cascade Elementary, Ephrata Middle School, Manson Middle School, Manson High School, Okanagan High School, Orondo School District, Pioneer Middle School, and Sterling Junior High. I thought it was super interesting that these referrals were mostly from middle schools. But of the 55 referrals that we had this year, 31 of them were from Ephrata Middle School. And I thought that was super interesting. I'm not sure why that is, but that is the information that I have. So the referral by grade, there was one 5th grader that was reported, and that was from Cascade Elementary. One 6th grader, there was 20 7th graders, 21 8th graders, 6 9th graders, and then it skipped the 10th grade year. And then we had 4 11th graders and 2 12th graders. So the referral by gender, there was 33 females, 15 males, 6 transgender, and 1 non-binary. For race and ethnicity, there was 32 Caucasians, 19 Hispanic or Latino, 1 African American, 1 Native American, and 2 were mixed race. So the type of referrals, there were 6 referrals that went to a teacher or a Hope Squad advisor. 11 of those referrals came from a Hope Squad member. 9 of those referrals were from a student that were not in Hope Squad. 20 of them were self-referred. 8 referrals were from the crisis lines, and 1 was from a parent. For the nature of suicide, there was 1 reported suicide attempt. Last year, we had 2 reported suicide attempts. We did have 7 reported self-harm with no suicidal thoughts. 27 of the referrals reported suicidal thoughts with no intent or plan to harm themselves. 7 had reported self-harm with suicidal thoughts. 11 had reported suicidal thoughts with an intent or plan. And 13 of our referrals had had multiple suicide-related incidents in the past year. Okay, so some of the things that we do with our Hope Squad is I try to be present at our Hope Squads. So I ask advisors if I can come to their Hope Squads meetings or any of their Hope Squad events. And some of the things that I was able to attend this year were their Hope Weeks. So this is a whole week dedicated to suicide prevention. This is put on by the Hope Squad students. So they'll do activities during lunchtime, they'll do raffles. There's all sorts of different challenges through the week. And every school does it different. It's just so fun to see the kids really getting into it and getting involved. Family events are also a great way to support our Hope Squads. This is really great for parents and really just being able to connect with them and give them the resources of suicide prevention and how to talk to our kids, and as well as mental health fairs. I was able to attend the Only 7 Seconds benefit concert in Chelan this year, and just being able to be at these fairs with other organizations and really just all have a common cause. So just being there for suicide prevention and really being there for our students. Some of the other things that we do is advisor collaboration meetings. So the Hope Squad Home Office does this on a national level, and they do theirs once a month. I try and do ours on a local level. So all of our advisors in the North Central Washington area that have Hope Squads, and I try and do them once a quarter. This year was a little hard just because we did have our conference at the end of the year, but I was able to do one in October and March. So a fall and a late winter, and then I counted the conference as the spring advisor meeting as well. I did have some time to talk to some of the advisors during the conference. And then the success, I would say, is the total of 8 new schools. This also includes our elementary schools that will be implementing in the fall of 2023. I also had the opportunity to attend the Master Trainer Conference. This was held in Provo, Utah in June. And so what this conference is number one, a way to collaborate with a lot of different advisors who are wanting to go a step further and help facilitate advisor trainings. So I was one of 30 new master trainers that I am now able to facilitate the advisor training, and I can do that via Zoom or in person for our schools now. So it's not just an online option. They do have that option to do the in-person now. I was also able at this conference to collaborate with some other people from around the country in kind of the same organizational standpoint as I was, just being able to facilitate on a regional level rather than just a specific school, and really pick their brain about just getting ideas on next steps moving forward in our Hope Squad. And I just wanted to end with the Hope Squad conference. We put a lot of time and effort. Thank you to Mariah and Teresa and Morgan and John for helping make this possible. So we have been planning this since January, and we really wanted to make it successful. I did receive a grant through the Community Foundation to help with some of the costs for t-shirts. Every single attendant got a t-shirt. It says North Central Washington Hope Squad Conference. So this was held on May 10th at the Wenatchee Convention Center. We had a total of 230 Hope Squad students, advisors, and administrators from 29 different schools that had attended this conference. It was so much fun. We also had the founder of Hope Squad, Dr. Greg Hudnall, come from Provo, Utah to be our keynote speaker for the conference. It was so fun to have him. We did do a guest registration, and we had a few members from different coalitions around the region, as well as some administration that are trying to get Hope Squad for their school, just to learn more about Hope Squad. And having Dr. Greg Hudnall there to answer questions and be an extra support was just so fun. And I learned so much from him. He also brought his wife, Melinda, who has a mental health background. So it was so fun to really get to talk to them and learn from them, and just watching them work and be involved with the kids. We did have 3 different breakout sessions that were offered. Dr. Julie Rickard shared her story, her personal story, and how she came into a career pathway of mental health. We also had Haley Croce, our Deputy Director of Together for Youth. She did a session on substance use and how it affects mental health. This was an interactive session. She had some workbooks for the students to really break it down a little bit. And then the 3rd session was an interactive breakout table discussion. So students were able to collaborate with other Hope Squads from around the region. And in the registration, we actually had a space where students and advisors could pick topics that they wanted to talk about during the conference. And then we just printed that list out, and then the breakout session, they were able to pick 2 or 3 topics during that time to really talk about different topics that they wanted to discuss and come up with some solutions and how to help their peers. And really the main thing with the conference was having an opportunity for our students to collaborate with other Hope Squads. It was so fun to see them interacting with each other, the junior highs and high schools, and really just seeing the confidence build up through the day. You could just see it like, oh my gosh, this is so cool. I'm a part of something. And just the fun that they had was just so fun to see. So these are some of the pictures from the conference. Dr. Greg Hudnall just got right in there and was talking to our students. And he was just so fun to have. On the left, this is our team, I guess, minus our Thriving Together team. But Dr. Julie Rickard there with Dr. Hudnall, who's the founder, myself, Courtney Cope, who is the AmeriCorps member for Together for Youth, and our Deputy Director, Haley Croce. Last year, I had talked about our one of our students from Waterville that was nominated and selected for the National Council. So Julia Ashley was able to come to the conference, and she, number one, introduced Dr. Hudnall as the keynote speaker. And she also, in the afternoon, did a pitch on the National Council. Unfortunately, at that time, all of our junior high and high schools had to leave due to sports and end of the day stuff. But we did record it. So we're going to share that video with our advisors and Hope Squads later in the year once the National Council application comes available. I would love to see more council members in our area represented, especially in Washington. So, and then these are just some more pictures of our conference. The one on the far left is Dr. Hudnall during our morning session during the keynote. And then I believe the one in the middle there is, I want to say it's Pioneer. And then the two on the right are just a couple pictures during our breakout sessions. So the next steps for our Hope Squad in North Central Washington is to continue supported growth of Hope Squad. I really want to try and expand the knowledge of Hope Squad in our community beyond just our schools, as well as increasing the total number of schools participating and really focusing on those elementary schools. It is new to me as well. So again, I will be learning alongside those elementary schools and really supporting them as best as I can. And if I don't know, then I will keep learning and finding ways to support them. The other things I want to do is increase community outreach. So I want to do more community QPR trainings and suicide prevention awareness for our community. I am talking with Shelly Sessler of the ESD to try and make this possible, as well as some other organizations that may be interested in helping as well. And the resources for parents, this has really been a struggle, I think, for a lot of our community, is finding those resources for our parents. Hope Squad does have a parent page, and they have family lessons that you can do at home with your kiddos, as well as they do have monthly newsletters that go through different topics through the year and how to help your child. They do also partner with parentguidance.org. That is also on the parent resource page. They have webinars on all sorts of different topics, as well as they do have a place for counseling. And everything is free except for that counseling part. And everything is available in English and Spanish. And lastly, we want to develop a sustainability plan. We have 2 more years of this grant cycle. So really continuing supporting our schools and finding funding for future past the 2 years. So that is all I have. Does anybody have any questions?
Thank you, Alyssa. Hey, I think you probably answered my questions. My question was like, I'm really engaged in Manson and Chelan Hope Squads and seeing how we can help. I think they didn't really know what they needed, and so I was kind of asking. I was going to ask you what kind of support can you use, or what do you think are your biggest needs?
I think it is hard because every school does do it a little differently, which is beauty of Hope Squad. There is a lot of flexibility, but the questions I get a lot of times is just for funding t-shirts and different swag items for Hope Squad. But as far as like resources for students and things like that, I mean, Hope Squad already has it lined up. So I think really connecting with the specific schools and seeing what their needs may be. They may not know right now, it may come up later, but just having them ready or be ready for whenever they may need something. I guess I'm not sure if that answered your question. So.
One idea I proposed to Manson and Chelan is we can teach QPR to the parents, and I was just thinking expanding that so that some of the parents' kids have been nominated by their peers as a Hope Squad or a person they can talk to, and then teaching those parents QPR. And I think that's what you're kind of going down that road. There maybe is our ability that we can support that way, where we teach the parents or maybe teachers in a school district who are not involved with Hope Squad to get QPR, or say
Yes,
for
absolutely. Yep. Yeah,
Or-
I would love to pick your brain about that, and maybe we can come up with a way to partner somehow. So
all right, we'll talk later.
thank you.
And I think we are a little over 4 o'clock. So I think, Alyssa, you had shared your contact information. If individuals have additional questions, they can direct them to Alyssa or to Mariah, who can direct them to her as well. But Molly, I'll turn it to you to close out. Thank you, Alyssa, for presenting.
Thank you.
Okay, John, you had someone who had connected with you.
Punching that to another time.
All right, well, that's good. Yeah, that's fine. All right, I'm getting ready to go ahead and adjourn everyone. Just look for lots of information coming by email. And then any questions you have, please respond so that we can communicate that way. And then the next meeting is October 6th. It is on the Colville Reservation in Nespelem at the Lucy Covington Government Center. Yay! So we will, I will hopefully see everyone there. And I go ahead and adjourn. Have a good afternoon.